En minut igen. Så vi klarar det.
Jag ska bara undvika att den där stänger av efter 5 minuter. Så
Oj.
den automatik så den stänger av. Så jag ska bara, därför växlar jag. Och så är det svart. Och så får man på din lösord igen och så vidare.
Ja. Så, då har vi en halv minut på er att komma och sätta er. Vi kör på klockan här. So, welcome down everybody to take your seat again. We have so much that we want to share with you, so we keep the times. So, ladies and gentlemen, the next speaker is from Denmark, Per Thorgaard. He's an anesthesiologist and intensivist in the field of children and neonates at the Aalborg University Hospital in Denmark. And he's also an advisor in the advisory board of the music therapy education in Aalborg. Those of you who are music therapists know that they have a huge department for research in music therapy in Aalborg. But Per Thorgaard is also a medical doctor, of course, since 40 years, but the last 3 years his focus has been to improve the quality of the patient's environment with a focus on sound. And one of the things he's done is being actively developing a playlist with different kinds of calming music to be played in the ambulance, for which he has given the Danish Music Award 2015 for the idea of the year. Yes. That is such an amazing thing. You'll talk about that. And currently, he is in the act of developing tomorrow's solution for how the room for delivery, that is childbirth, can be designed. So the room where the new babies come into life, that's also important. And the sound milieu there. So, Per Thorgaard, the stage is yours.
Thank you so much. And thank you for this very nice introduction. Thank you. I'm very honored to be here. It's a pleasure and an extra pleasure to be in these nice surroundings here. And wow, it's the first event here, so fantastic. I'm a medical doctor, and I've engaged with the task today to speak about the doctoral point of view or a healthcare professional in this context. And I'll stick to that, so it's going to be practical, and I'm going to talk about what we all can do in our practice. That is, I hope that when you listen to me for 40 minutes, you'll be able to go home and think about your own practice and think about how to change it. So it's very nice with this national policy, with these regional policies, and all this working together with decision makers, but it's also very important that you take responsibility and do something about it. Maybe it's my doctoral education in intensive care for neonates, the most vulnerable patients of all, that has learned me that it's not enough with ventilators and machinery and drugs to save the life of children. You have to think about not distressing them too much. They simply die from distress if you don't take care of the environment. Maybe that's what inspired me some years ago to go into this. And I'll talk about my experience and maybe also the advice for the future and bring some news to you, I hope. I come from Denmark. All the Swedes know who we are. These are our national colors. And a lot of water and a lot of islands. We have the Faroe Islands in the upper corner. I've not taken Greenland with me in the picture, mainly due to its size, because we are only small dots compared to Greenland. And then I can tell to the British here that the people of Greenland have been very inspired by the British Brexit, so then now they also want to be them for themselves. Sweden, Norway, and Denmark are engaged in teasing each other constantly. I think that the Norwegians tease the Swedes with the skidåkning, skiing. I have a teaser here because Denmark used to be behind in all sports, but recently we had the world-leading tennis player, Karolinska Universitetssjukhuset. So this is a teaser, and it's one of the only areas where we are the best in the world. Certainly we are not the best or world-leading in any way concerning culture and health. But we are improving, and I'm going to talk about that. We're improving mainly due to organization, and we are committed to this task, and also that we have had this very skilled person in the upper right who is present here today, Anita Jensen. She was mentioned previously today, having held a speech at the British Parliament, apparently. But now she is leading the initiative in Denmark and organized in NOX, which I'm going to talk a little bit about, where people with different competences, music therapists, academics, doctors, municipality and regional politicians are all present. And that's a very strong way of organizing yourself. Recently, we had a Danish book in culture and health called Kultur og Sundhed, and Anita has also been edited that. And she also made an article quite recently, within the last weeks, in the Danish Doctor Journal, which is also completely new, that doctors accept this as part of their journal, as part of treatment. I'm very thankful to that, and all this is mostly due to Anita's initiative. I also have to say that even though we are Danish, and actually this organization is from North Jutland, we are very interested in collaborating with others, and Anita, certainly also with the British. Anita's background is actually that she made her thesis in England out of Nottingham University. So we have a lot of international knowledge, and we are very keen on collaborating. This is how Denmark is divided into region. It's a tiny country, so it should be one region, but it's not. It's 5 regions, and I'm in the upper north with 600,000 inhabitants. We have this rather small city in the center where I stay, at this hospital. It's a very complex hospital with buildings up to 120 years and down to 10 years. So they've decided that these very mixed frames should be gathered in one new hospital. I don't think it's going to be as nice as this one, but this is a drawing of it. Irrespective of the frames, it's what's inside and how we behave that makes a difference, in my opinion. So I'm not going to talk about this. I'm not going to talk about this either. But I will mention that this is a science. This is scientific knowledge concerning the healing effects of architecture. So it's not to not mention it. That's not why. I have a limited time, so I'll not go into this. We have also in Aalborg University an institute for this, led by Michael Mullins, professor. I'm not going into this. We have heard a lot of numbers, and even being a doctor who are very keen on numbers, we really want to know about numbers and significance and so on, scientific significance. Just want to say there's fastly accumulating evidence on this. This is the curve for randomized controlled trials concerning music intervention. So this is growing immensely. And one could say that we need more information, we need more science. But on the other hand, this is how it looks for medicine and surgery. It's not you're allowed to kind of act at some point of time, even though you know that in 10 years you have additional knowledge. So my comment to this is we have to act now. Time is mature, we have a lot of knowledge. It's not a lack of knowledge that kind of hindrance for acting. It's some other factors. Amongst them, unfortunately, the doctoral attitude to this. Why do we need rethinking and acting differently? Because that, I would like to talk a little bit about that, because even doctors recognize this. I borrowed this from Gitte Wille from Skåne. And this is how disease waves through the last century, 100 years have looked like. Initially, it was infectious diseases. People died in all, many siblings dead, up to 20% even in Scandinavian countries, lost their lives in childhood due to infections. Then the doctors invented this chemical, remember it's a chemical called antibiotics, and that disease wave is not disappeared, but it's minimized. Maybe it's growing again a little bit due to resistance, but that's another story. Then we had accidents and cardiac disease and so on. And we also kind of fought that with success, using chemicals, that's medicine, or surgery, or some other intervention, balloon, and so on. But now we're facing new things that's growing fastly, and we can't kind of make surgery to fight that, and we can't only. We have to supplement the chemical treatment with some other things. It's diseases related to aging, and we call it in Danish the S diseases. That means anxiety, distress, depression, so on, related to environment, society, working conditions, and so on. So this is why doctors and health care decision makers have to do something else. Then the question is, would this be a new possibility? And as I showed by the literature, it certainly is. So the doctors have to find and identify the common ground between culture and health and use that in their practice. Now these circles, the red one and the green one, are drawn in equal size, which is not true related to economics, because the healthcare is much more heavy than the cultural budgets. And we'll have to think into that too. I should speak about patients, but how do they look? And that's also one of my points here today. Hopefully that patients, you would probably guess that they are in the upper two pictures, and of course they're patients, but most patients are not at hospitals anymore. In Denmark, we have at our hospital 800,000 one-day services, same-day services for patients. That is, they come and they go on the same day. Whereas we have 80,000 in-house patients, that is, admitted to hospital, stay there for a while and go home. So 10 times as many come and go on the same day. So it's a very hectical contact. And even though you stay in-house in Denmark, it's only for, at the moment, 4 days on average, and we're going down to 2 days on average. So patients are not at hospitals. Patients are out in society. If we have to do something about culture and health, it's not enough that we reform or do something at the hospital in-house. We have to kind of build a bridge to society, and the initiative that we initiate should also be continued some way in society. So we are all patients, and patients are not dressed like with gowns and so on. They're dressed like you. So we have to engage with municipalities in order to follow the patients out in society. It's a common task. That's an important thing, I think. That's why this index finger is raised. Every time you see that, I kind of stress that this is important. How do we treat them when they are at hospital? We treat them like when you put your car in a garage. Maybe this looks a bit dramatic, but actually we are dressed like that. Of course, it's to fight infections and so on. But it looks very much like people working in a garage. And patients are lying there more or less equipped with drugs and tubes and so on. And this is, of course, not everyday practice in every hospital bed. But activities like that is at least 10% of hospital beds today. So this is very common. How can we kind of think about environment in that context? Look at this. Some have thought about we have to do something about sound environment, putting earphones on this small child, and that's the intention is good. But 5 seconds after this, you know, the child has vomited on the earphones or something else is wrong. So this is not the way to do it. So we have to kind of invent new technologies and direct technologies into fulfilling the task. How can we engage with culture, being a patient at a hospital? Also thinking about fire risks, infectious diseases, and so on. So there is a technological development that should be done. This is also a part of a practice in some hospitals. This is from an American hospital. Again, I think the thought behind it is very good. I asked actually this musician whether this was the right instrument. If I was lying in a bed and I was sleeping and hearing this, I think I could have some wrong thoughts. But my message is that environment in hospitals, if we don't think about it, is quite hostile. There's a child in the center of all this. There's also a child lying here. You see all the equipment is close to her ear. Actually, it's not been moved away from her in any way. So she's exposed to all the sounds, all the alarms and everything. We thought a little bit in this relationship about colors, but she's not awake. She's not looking at the colors. And if she was awake, she would look at the ceiling most of the time. So we have to rethink our practice. This is just an example. Because not being professionals, they can rethink. This is actually the same patient. You see, she's improving a lot, still in the ICU, connected to a ventilator. But look at her sister who is visiting her. She's creating a kind of environment with this nalle, it's called in Swedish. And that's just an impression that everybody actually know what to do, but kind of we've forgotten it. Sound level is terrible in hospitals, and it's rising. I would think that old hospitals with these, like that in the upper right corner, had terrible sound levels, but that's not true. New hospitals are built with even more noise than the old hospitals. So, and we also have these ethical considerations. It's easier for us to kind of think about it in hospices where people are to die. They know this is the last end of my life. But in acute situations in hospitals, you experience this. Being an anesthesiologist, I've often been engaged in such situations. And I know that this poor fellow lying there looking not well, unhealthy, I will say, he may die. And the last sense that he loses when he dies is probably his hearing. So also there you have to kind of reflect on how should it sound when we die. We're all going to die, unfortunately. How should that sound? Think about it. I'm skipping that. This is my last and my conclusive slide concerning how we behave in hospitals if we don't do anything about it. This is a small Dane called Magnus, which means great. His mother has brought some stimulation, visual stimulation to him. Even though he don't see the first days of his life, I think it's a nice initiative. But you can't read it, but he's dressed up in white. And with yellow writing, we have written on him, belongs to the laundry. So, I mean, we do not think about it. The healthcare professionals, others, they don't consider, they don't think about it. If we're not focused on this, we're doing something wrong. So go ahead, make a change. One of the changes in the hospitals could be, this is in Danish, to write it into the list of tasks that should be done. This is on the recovery room after anesthesia, and a lot of things are written down with blood pressure and cardiac monitoring and so on. And what I've made the red dot is you should also provide a music pillow. So that's one of the standard issues in this setting. So that's a good way of kind of making a change. Ambulance project, I'm going to show you a little film, because that's another very practical issue concerning how to make things different by just considering how we're doing it today. When we began, that was a standard ambulance, and the standard ambulance was equipped with a siren, which all ambulances need in order to move in traffic. But the siren was situated right over the patient's head, and there was no insulation between the siren and the patient. And the ambulance was equipped as a truck. It was not allowed, actually, if you look at the specifications, to transport animals in this. The regulation for animal transports were tougher than they were in ambulances. So we began with the sound and said, this cannot be healthy. We investigated 17 people putting on microphones when they were collected at home, all with cardiac diseases, and we listened to what they heard during the transport, and we asked them what the most frightening thing about the whole event was on the next day, and they all said the siren. In a visual analog scale, they scored 9 to 10 in anxiety due to the siren. So it's the most frightening sound you can ever have. And we put them right into the head of the patient when they are in the most vulnerable situation. They're not at hospital yet. They're out in the outskirts of Stockholm or far away. In Denmark, up to 100 kilometers. So we thought we have to change this. We have to do something about it. Actually, one of the patients died during transport, so we sat there with our coffees and listened to how it sounded during the last seconds of his life. That was quite a stimulation to change. And this is how we wanted it to be, kind of. Wouldn't that be nice? Now I show the reality, and this is a very short film, but it's all acoustics taken from the ambulance. All voices, all human voices are taken out. That is a patient with a cardiac disease being picked up by the ambulance. Before we changed it. Doors are slammed. Doors are not closed, they're slammed. This is inside the ambulance, and now we have the doctor is moving out to meet them on the road on their way in. So that's why they meet here, and the doctor enters the ambulance. Voices are often electronic. That means the machines are talking to patients. It's not a human voice, it's a machine talking. In Danish, this means don't touch the patient. That's what the patient is listening to. It's the same here, I think. Many patients close their eyes during transports in order to avoid all this, but they can't close their ears. Remember that. So ears are always open. So they're exposed to all this on their way home. I'll stop this because it's not nice. And of course we had to change that. And we changed it and succeeded in changing it by pointing the siren in another direction, make installation in the ambulance. And the ambulance company improved the vibration so that now it's like a limousine and not a truck anymore. And the music is composed by music or selected by music therapists. I'm not going to show that here, but music therapy has helped us picking out a variety of pieces that can be selected for that individual patient. And they have an interface called the Music Star, and it works very well. I think this has really changed the life for many Danish patients going in ambulances, and I hope it's going to spread to other countries too. Lego, the famous Danish company, actually awarded us by building a music ambulance, half-size, original. It's exhibited in Legoland in Jylland, and I think it's a very nice award for that initiative. Another award was that I was given the Danish Music Award that year, and this is the event. Yes, thank you. And this is the event, and I was thrilled. It was fantastic being a doctor with a musician and entertainers and so on, and having this award. That was very nice. And for the politicians here, I would say that during the next couple of hours, I had over 100,000 likes on this, which means, and it's not to of course I'm proud, but I mean, people want this. People want this initiative in order to improve their well-being during ambulance transportation. So there's, out in the population, there's a broad support for this. What about childbirth? Yeah, this is in English, so I thought we could read this English Winston Churchill sentence. We shape our buildings, and afterwards our buildings shape us. 1943. This is a standard room for delivery. And why should it be so? Because we have some technical improvements during the last year. On your left-hand side, you see the Apple computer 1983. Now, you see a patient's hand, you see it on the x-rays. There's a small device there which actually tags him. It's a tag, so that he can enter buildings by having this tag in his hand. So we have had a lot of technical improvement. So this very luxury, in my opinion, room for delivery is very sterile, and you don't feel as a family when you are there. That's my judgment. And one of my friends, I worked together with him, you'll see a small film in a short while, he went there to have his first child and thought, this is too bad, like the ambulance story. And he said, why don't we make it like this? This room is with white walls, so all the tapestry, all the view is done by computers. And the furniture are non-flammable, and they're according to all hygienic standards. And this is actually a delivery room in Jutland. You see the bathtub too? It's working, and everybody wants to have their child in rooms like that. You can change it all by pressing a button. So that depends on your mood and where you come from and the time of the day. So you can in any way engage with the room. I'll show you a short film. Unfortunately, it does not work well here, so I have to take the presentation directly. Sorry for that. It'll come up here. Then you can see Esben and listen to some of the patients there. It takes a few minutes. maybe it won't work anymore. Sorry for that. I don't know why it doesn't obey. No, it won't work. Sorry, but the whole idea is that you can change this room and you can be so. Now I've ruined it all. This won't work. Maybe I need some help now. It could look like that. Harris, help. Maybe somebody else. I'll go back to this. Yeah, and this was it didn't work before. It does now. Okay. I think it's coming up now. Good. I can't show the film, but we've doing this as a study. So this has not been written in as a paper yet. It's coming up. It's more than 600 births in that room. And already I know the results. Of course, I can't talk about it. But a lot of other rooms similar to this has been equipped now with the same equipment. So, of course, it's nice to have a standard with this quality. But we're not able to do that everywhere. It's too costly and we can't. So you can take other technical equipment and help yourself in creating an environment. This is Espen, who I'm working with, and he's very inspiring. He calls himself now Counsel in Poetic Technologies. A doctor, I don't know, but I think it's good. And it's been very popular, and that's going to change the Danish delivery system. Be practical and innovative. Look for new solutions. Go home and change the world you live in. What about politics? I'm not going much into that. We have this fantastic speech by a member of parliament in England. They're not Danes, any of those. We have one Australian, I think originally, Schwarzenegger, I think he's Australian. No, he's from Austria. Austria, yes. But the point is that they are there, they're very important, but they're also very different. And things may change, even though you think now we're doing something which is good. Then another guy pops up and things are very different all of a sudden. So I think, of course, these are the local politicians, the dean and the regional leading politicians and the municipality leading politicians, my own boss, who's a director of doctors. And it's very important to work together with those. And I'm just going to talk a little bit about how we work in our region. Anita is also heading that organization, NOX, who is really an umbrella where all the bosses from the region, from the municipality, from the university, and from the hospitals have written, we have opened doors to everybody regarding this initiative. So nobody is allowed to close the door. The doctors cannot close the door and say, this has no meaning for us. They may be skeptical, but they're not allowed to close the doors. That has been a huge advantage for us, that the bosses have written this collaboration agreement, and they've set down the steering group, and here you see some of the guys. Anita is down there, and I'm up in the middle, and to the right, in the upper right corner, is the university link, is the Institute of Music Therapy. And I want to stress again that music therapy is very important in relating to making this scientific. As a doctor and as working in healthcare, and I know also for the politicians, it's very important that we have science into this. It's very important. So we're working actually in three major initiative areas. We are building, Anita has built the scientific knowledge. She's collected all that. The RCT studies, so you can find that on our homepage, and she updates it every second month or something like that. So all this solid knowledge can be found. We're actually trying to expand that into practical knowledge. Because one thing is reading articles with p-values and so on, but that bank of knowledge should also engage practical ways of doing things, like the ambulance, like Espen's delivery rooms, whatever practical solution there could be, we want to put into this as library number 2. Because I think it's it's a high value for all the practical healthcare workers and everybody else to look at the solutions. So we're also working with that. We're working a little bit with active research. We're not a research organization, but we think we have to highlight new areas. And one of the projects we are now launching is very much like when you think of patients as hospital patients. They're not. They're out in community. The myocardial infarction patients, they are at hospitals 1 or 2 days in Denmark. And they have a 12 weeks recovery or rehabilitation program run by the municipality. And we link that together. And every second month we give them a cultural offer, and every second month we don't. And then it's a science, and we measure and interview and so on. So in our research, we focus also on this longitudinal disease courses. And then we think we have a great task in communication, not just by standing up here on conferences, but also engaged with educations in healthcare. We also now soon, hopefully, launch an active advising group of nurses. We have in Denmark, I think we've copied a Swedish initiative. We have nurses sitting on a call center, and patients recently, day-to-day basis, going home from hospital, have a phone call from these nurses because they're at high risk of being readmitted. And they will have advice on the municipality where you live. You can go to the choir, you can go wherever. So they have knowledge on these offers. One of the offers I'm a bit proud of. It's not my own invention in any way. It's by the municipality in Aalborg. It's called culture vitamins. And that's not in order not to engage with medicine, because that's a little bit touchy. It should be an open dialogue in 5 years, but at the moment it's not, because then health authorities should be engaged. But vitamins you're allowed to take, and there are a lot of vitamins in a 10 weeks program, and one of them would be choir, another would be coming to the rehearsal of the symphony orchestra, and the way into this vitamins are people being unable to get back to work with usual medicine. So they have another medicine, and one of the guys, the guy leading it, and I think he's very important, and you may connect with him, he's also here today, is Michael Other. He's sitting beside Anita. And I think it's a very important thing for those people who can't sleep, they can't go to work, they can't do anything, that when they're invited to listen to the symphony orchestra, they have a personal contact. There's a guy standing there telling them, welcome, come in and sit down. I'll be by your side the first time or maybe the next time. Michael can tell you a lot bit about that. We engage at the hospital. We can contribute with the ambulance experience, with the post-anesthetic care unit, where music is standard. Hospice, of course, where the music therapists are doing a great work. Our cardiac labs, and not least our psychiatric ward. We have 4 music therapists there. They're doing a great work. University is very important. I think this should be knowledge-based. It should be solid knowledge. But politics and strategy, very important. How should we make the change? I'm almost finished now. I don't think we should impose this by violence or in any way pointing at somebody, especially not this cute little kitten. I think we should look for possibilities in all directions, really use our ability to orientate ourselves and see what's in all directions. And using that, I'm sure that you can change the world sooner or later. Thank you for listening.
Thank you so much. I will take the opportunity to start with a question, because I think you were a bit quick there with the music star, and that everybody got that it's actually an app with 6 different genres that you can choose. So it's this person-centered idea. It's that you really meet, and you also had that with these images, the database in the room. Could you say something more about that?
Well, one of the problems for I'm not a scientist in music in a way. One of the problems of how to choose right in relation to feelings and experiences. Of course, you can ask the patient, but if he's unable to answer, maybe he's frightened or unconscious, how do you choose? And then these music therapists have invented a star where you, by colors, can choose whatever color you should pick up for this patient. Or the patient can choose a color if he can't choose a specific theme. That works nicely. So
and
it's
that
a
says
user
something.
interface.
Yes, and that says something that reinforces the idea that it's not like a pill. It's not
No.
like you take Mozart and then you get well. But it's the relationship between the person and the music and or the images.
Yes.
Yeah. So questions from the audience.
No questions? Is that good or bad?
Or comments? Associations, comments?
Go who make
Do you
a
see
change.
the opportunities?
Yeah.
Yes,
Hopefully.
there was one.
Has this been tried in Sweden?
Yes, some of it has. I mean, this has been tried in various varieties, and a lot of projects, as has been mentioned before, have popped up in various places, but many of them have kind of died when the project phase is over. So we are one of the few who managed, and I think that public support, this music award, really helped us in that.
And there was one more. No? Yeah? Short one.
Hello. I think it's very interesting that you consider sound in space, the connection, because I experienced a small episode at the intensive care for my heart, and that was the most stressful experience I ever had,
Yes.
because there was all these machines making sounds, not only for my status, but
Also
my
yours,
neighbor's
yes.
status, and
That's
everybody's running 24/7 in the rooms.
Yes.
So when you need to rest the most, it's totally impossible.
Exactly.
So it's sound polluted.
We're all patients. There you got
Yeah.
one of them.
Yeah.
An experience. Yes.
Yeah, thank you.
Thank you.
So, thank you.
Thank you.
You get flowers from the other place there.